Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 150 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, T.B.M. is a 47-year-old male patient with a height of 72 inches, and a weight of 95 kilograms, who will be admitted to your medical intensive care unit, because of presumed septic shock from community-acquired pneumonia. His history of present illness is significant for an influenza-like illness which occurred 1 week ago. He is to be treated empirically with ceftriaxone, azithromycin, and vancomycin. His pertinent lab values include a serum creatinine of 2.1 mg per deciliter, a BUN of 25 mg per deciliter, a WBC of 22 × 10³ cells per millimeter cubed. So my question to you is, which of the doses listed below would be the most appropriate loading dose of vancomycin for T.B.M? Would it be A. No loading dose is recommended, or B. 2,500 mg, or C. 2,000 mg, or would it be D. 1,500 mg? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. 2,500 mg. The vancomycin monitoring guidelines recommend loading doses in patients who are critically ill with potential invasive MRSA infection. Answer A is incorrect. The recommended dose on the basis of actual body weight is 25 to 30 mg per kilogram, making 2,500 mg the most appropriate answer, that is, answer B is correct. Answers C and D are incorrect because the doses are too low. And the next question reads, the clinical team diagnoses T.B.M. with methicillin-resistant Staphylococcus aureus, MRSA pneumonia, and azithromycin and ceftriaxone are discontinued. On day 5 of vancomycin therapy, the trough returns at 10 mg per liter after previously being 20 mg per liter on the chosen maintenance dose sampled on day 2. So my question to you is, which of the following statements is the most likely explanation for the change in trough concentration? Is it A. Liver blood flow returned to normal, or B. Tissue penetration decreased to below normal, or C. Volume of distribution, V.D., increased to larger than normal, or is it D. Acute kidney injury resolved? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Acute kidney injury resolved. Patients presenting with community-acquired pneumonia after an influenza-like illness are at increased risk of Staphylococcus aureus infections, including MRSA. Often, these patients are very ill with septic shock, which is another association with MRSA pneumonia. However, most acute kidney injury will resolve with fluid resuscitation, which is likely in this case, which makes answer D correct. Liver blood flow would not affect vancomycin clearance directly, that makes answer A incorrect. Lack of tissue penetration or change in volume of distribution (VD) would not explain that degree of change in vancomycin concentration. That makes answers B and C incorrect. Let's move to the next question, please. And the next question reads, SGY, a 57-year-old immunocompetent man with a MDR Pseudomonas aeruginosa pneumonia, currently receives standard dosing of piperacillin, tazobactam, that is 3.375 grams IV every 6 hours with each dose infused over 30 minutes. The attending physician asks for your expertise regarding extended infusions. So my question to you is, which is most accurate regarding extended infusions of piperacillin, tazobactam? Is it A. Extended infusion dosing regimens are now U.S. Food and Drug Administration (FDA) approved for most beta-lactams? Or B. First doses of piperacillin, tazobactam should be given by traditional 30-minute infusions, especially in critically ill patients, or C. For extended infusions to be effective, concentrations should be above the minimum inhibitory concentration (MIC) for the entire dosing interval, or is it D. Peak drug concentrations are the most important pharmacokinetic (PK) parameter when considering prolonged infusions? I will give you 10 seconds to choose the correct answer to this question from the listed options. Target attainment greater than 90% is considered adequate dosing for a particular MIC. At an MIC of 2 mg per liter, only a dose of 300 mg every 24 hours achieves a target attainment. And the correct answer is B. First doses of piperacillin, tazobactam should be given by traditional 30-minute infusions, especially in critically ill patients. Modified dosing of beta-lactams, including extended, typically 3 to 4 hours, and continuous infusions, is becoming more common in clinical practice. When initiating extended infusions, the first dose should be given as a bolus over 30 to 60 minutes, depending on the agent, to ensure timely therapeutic concentrations, especially in critically ill patients. That makes answer B correct. Although extended infusions of beta-lactams are being used more, FDA approval for these infusion times is rare. That makes answer A incorrect. The point pharmacodynamically of extended infusions is not to increase the peak because this has little effect on the effectiveness of the beta-lactam, which makes answer D incorrect. In immunocompetent patients, maintaining concentrations above the MIC for 50% of the dosing interval for penicillins is sufficient to provide clinical effectiveness. That makes answer C incorrect. Let's move to the next question, please. And the next question reads, which of the statements listed below is most accurate regarding continuous infusions of beta-lactams? Is it A. Labor and administration costs are increased over traditional dosing methods, or B. They are best studied and mainly used in the inpatient setting, or C. Compatibilities are the most practical limitation in clinical practice, or is it D. They have shown consistent clinical cure superiority over extended 3 or 4 hour infusions of beta-lactam? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Compatibilities are the most practical limitation in clinical practice. Although extended infusions and continuous infusions of beta-lactams are used in clinical practice, most practices adopt extended infusion methods because of concerns over compatibility issues that occupy that particular intravenous line for the whole day. Therefore, most use of continuous infusions occurs in the outpatient antimicrobial therapy arena, abbreviated as OPAT, such as continuous intravenous nafcillin for a patient with MRSA osteomyelitis. That makes answer C correct. Answer B is incorrect. To date, there are no conclusive data that continuous infusions are superior to extended infusions for clinical outcomes. That makes answer D incorrect. Costs usually decrease when using continuous infusions because they use less labor and sometimes fewer overall medication dosages, which makes answer A incorrect. And the next question reads, as the clinical pharmacy infectious diseases specialist in your hospital, after consulting with key stakeholders, you have decided to implement extended infusions of piperacillin, tazobactam at your hospital after developing a protocol. So my question to you is, which is most accurate regarding education of hospital staff about extended infusion protocols? Is it A. Education of the process should primarily be targeted to microbiology staff, or B. Education is a low priority in the overall protocol implementation process, or C. Frequent re-education is required to ensure compliance long-term, or is it D. Most education is done after implementing the protocol? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Frequent re-education is required to ensure compliance long-term. Education is one of the most important parts of the implementation process regarding extended or continuous infusions. That makes answer B incorrect. Most education must occur on the front end before implementation, both to obtain stakeholder buy-in and to educate all of the providers who will be involved in prescribing, administering, distributing, and monitoring these agents. That makes answer D incorrect. Although microbiology staff are an important part of the antimicrobial stewardship team, they are not the primary targets of education, which makes answer A incorrect. Frequent re-education is required to secure the long-term success of the protocol, which makes answer C correct. And the next question reads, which of the statements listed below best depicts a potential barrier to successful implementation of extended infusion piperacillin, tazobactam? Is it A. Decreased effectiveness in patients with renal insufficiency, or B. Lack of provider buy-in including infectious diseases, ID physicians, or C. Sparse data regarding stability at room temperature of mixed solution, or is it D. Increased cost of antibiotics compared with traditional infusions? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Lack of provider buy-in including infectious diseases, ID physicians. Lack of provider buy-in is an important reason why implementation may fail. All key stakeholders should sign off on extended infusions because of the significant change in dosing schemes that will be used. That makes answer B correct. However, although data are limited in patients with renal insufficiency, this would not be the primary barrier to implementation, which makes answer A incorrect. Many hospitals have adopted extended infusion practices because of decreased drug costs. That makes answer D incorrect. Significant data are currently available regarding stability at room temperature. That makes answer C incorrect. Let's move to the next question, please. And the next question reads, a patient with MRSA bacteremia who is receiving therapy is on your infectious diseases consult service. The Infectious Diseases Fellow asks for your expertise regarding vancomycin pharmacokinetics and pharmacodynamics, abbreviated as PKPD, so my question to you is, which is the most appropriate answer? Is it A. GUL AUC to MIC ratios are well defined for MRSA and Enterococcus species, or B. Continuous infusion vancomycin is superior to traditional intermittent dosing for clinical outcomes, or C. GUL vancomycin AUC to MIC ratios for invasive MRSA infections should be 400 or greater to optimize clinical outcomes, or is it D. Vancomycin troughs of 15 to 20 mg per liter correlate well with area under the curve, that is AUC to MIC ratios? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. GUL vancomycin AUC to MIC ratios for invasive MRSA infections should be 400 or greater to optimize clinical outcomes. The current vancomycin guidelines recommend an AUC to MIC ratio of 400 or greater to maximize clinical benefit in the treatment of invasive MRSA infections. That makes answer C correct. Although trough targets are 15 tp 20 mg per liter for invasive MRSA infections are recommended, data analyses recently showed that the correlation of these targets to desired AUC to MIC ratios of 400 and greater is inconsistent. That makes answer D incorrect. Although continuous infusion vancomycin is still used in some clinical practice, there is no evidence that it is superior to traditional dosing for clinical outcomes. That makes answer B incorrect. The current AUC to MIC targets are for MRSA only, not other organisms such as Enterococcus or coagulase-negative staphylococci, which makes answer A incorrect. And the next question reads, which pharmacokinetic pharmacodynamic, PK/PD parameter listed below best predicts the efficacy with fluoroquinolones? Is it A. post-antibiotic effect, or B. time above MIC, or C. peak to MIC ratio, or is it D. AUC to MIC ratio? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. AUC to MIC ratio. The efficacy of fluoroquinolones is best predicted with AUC to MIC ratios. That makes answer D correct. The other parameters best correlate with other antimicrobial agents, which makes answers B and C incorrect. While fluoroquinolones exhibit a post-antibiotic effect against some organisms, this is not the primary parameter that predicts efficacy. That makes answer A incorrect. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 151.